Hello and welcome to today's CAPE webinar. My name is Daniel Ting. I'm an emergency physician based in Vancouver and a clinical instructor at UBC. I'm also the editor-in-chief of the medical blog Canadian.org and a decision editor at CGEM. Our webinar topic today was independently conceived by our scientific planning committee, Drs. Stacy Kitts, Eddie Lang, Rob Stenstrom, and Kirat Graywall. My disclosures are as follows. Next slide. And the other committee members had no conflicts of interest to declare. This program received financial support from AstraZeneca in the form of an education grant. AstraZeneca is the manufacturer of ZS9, which is an oral potassium binding agent. AstraZeneca had no role in the development or the delivery of the content presented in this webinar. All efforts were made to mitigate any potential biases. And just to give you guys a bit of background on today's webinar development, hyperkalemia is a common electrolyte disorder that we see in the emergency department. Because of its cardiotoxic effects, hyperkalemia is also the most likely electrolyte emergency to lead to cardiac arrest. Therefore, as emergency physicians, we need to be masters in the management of hyperkalemia. In a recent CAPE needs assessment survey, 100% of respondents indicated that the management of hyperkalemia was an important skill for emergency physicians. However, when they were asked to rate their own skill in managing hyperkalemia, the responses rated from about 50 to 75 out of 100. So hopefully this webinar will help to bridge that gap and to help you to up your game when it comes to the management of hyperkalemia. Our learning objectives are as follows. And we just saw the slides there about the CanMeds roles that we will be covering as well. So just to give you some of the take homes from the beginning here, we're going to be really addressing 5 principles for the management of hyperkalemia. I'll wait for that slide to come up here. So protecting the heart, thinking about artifact, shifting potassium, eliminating and not adding potassium, as well as finding the underlying cause. And then there's also going to be 3 common pitfalls that we'll be covering along with 3 cases. So to increase the interactivity of this session, we encourage you to use the chat feature just to drop in any questions. We have, after each case, we'll be pausing to take up some questions, and we'll try to answer as many of those as we can. We'll also be using a few polls. So there's a website, menti.com, as well as a code that's on the screen. You can also scan your QR code with your mobile device. Without any further ado, I want to introduce our 2 fantastic speakers for this webinar. I've actually been a big fan of both of these individuals since their great EM Cases episode on hyperkalemia. I've already learned a ton about hyperkalemia just from preparing this webinar, and I am sure that they'll be sharing lots of great clinical pearls for you guys as well. First off, we have Dr. Ed Etchells. He is the head of the Division of General Internal Medicine at Women's College Hospital in Toronto. He is also a senior mentor at the Center of Quality Improvement and Patient Safety, and a professor of medicine at the University of Toronto. Next up, we have Dr. Melanie Baymal, who is an emergency physician at Sunnybrook Health Sciences Center and Credit Valley Hospital. She's an assistant professor at the University of Toronto, where she completed her family medicine training with an emergency medicine fellowship in 2011. She's an award-winning teacher and is very active in teaching at both the undergraduate and postgraduate level. So we'll just quickly go over some of the disclosures here for Dr. Etchells and Dr. Baymal. And then we'll just jump right into our first case. So case number 1, this is Dorothy. She's an 84-year-old female. She is presenting with 2 months of generalized weakness and weight loss. Next slide, please. On history, we find that she's got atrial fibrillation as well as hypertension. She's on apixaban and amlodipine. We do some basic labs, and there are a few labs that jump out. Notably, her potassium is quite elevated at 9.7. She's also got a very significant leukocytosis as well as an anemia. Next slide. So as Corey Slova says, hyper-K ECG. So of course we have an electrocardiogram here. This is a tough one. I'm gonna let you as the audience look at this for a few seconds here, and then we'll get Dr. Baymal to jump in. Again, the case shows a potassium of 9.7 and the following ECG. Okay, so I think that's given a few seconds there to take a look at it. Dr. Baymal, why don't you walk us through your interpretation of this ECG?
Thanks, Dan. So Dorothy is going a bit fast. Her heart rate is around 114. The rhythm is irregularly irregular with no discernible P waves. She's in AFib. And the QRS looks mildly widened because of a right bundle branch block.
Awesome. Yeah, it's a tough ECG for sure. Okay, so why don't we jump to the next slide there and we can go over the first poll. So again, hopefully you'll be able to log on to menti.com or scan the QR code previously. And these are just the 5 options that we have for the management of Dorothy. So first option is to give calcium chloride. Option 2 is to give calcium gluconate. Option 3 is to give insulin. Option 4 is to give D50. And then option 5 is to repeat the plasma potassium level. So I'll give you guys a few moments there to answer those. Great. So why don't we take a quick look at the poll here. All right, so we got a few votes here for calcium, primarily calcium gluconate, it looks like. We have 1 answer for calcium chloride, 1 answer for D50, and a few answers for repeating the plasma K, and insulin seems unpopular. Okay, so maybe, yeah, Dr. Baymal, why don't you walk us through some of the right answer here and some of your reasoning behind it?
Sure. So the right answer here is to repeat the plasma K. It wouldn't be wrong to give calcium, as many of you have decided on. But if you were worried that there were EKG changes, she doesn't have specific EKG changes of hyper K, certainly not a K of 9.6 or however high it was. So in this case, the right answer is to repeat the plasma K because this is a case of, next slide, pseudo hyper K with in vitro cell lysis. So you'll recall that Dorothy had a white cell count of over 400. Leukemic cells are inherently more fragile than normal white cells. And when the sample was resent gently and promptly after being drawn to the lab, her potassium value was 4.9. Next slide.
Okay.
So the moral of the story here is to pause when the potassium value doesn't correlate with what you're seeing clinically and also on the EKG. She was chronically unwell, but not acutely unwell. And we want to avoid shifting in these cases so that we don't cause inadvertent hypokalemia and hypoglycemia. Next slide. Next slide. Oh, yeah. So if there are no EKG changes and the patient is relatively asymptomatic, then you have time to place them on a monitor and recheck the potassium before shifting. But it's never wrong to give calcium. So if you're concerned and if you think there are EKG changes or you don't have another ECG to compare to feel comfortable, then I think giving calcium is reasonable, but I would definitely hold off on shifting until the repeat potassium comes back.
Awesome. So let's see if you have any questions in the chat about case number 1. So again, if you're watching, you have a question, just drop it into the chat. We have one question from Prav who says, should the repeat sample be sent to the lab or is the VBG fine?
Good question. I think it depends on how accurate you think the VBG measurement of the potassium is. I would rely on another sample being drawn and sending to the lab. I don't know, Ed, what do you think?
Yeah, it's Ed. I think a VBG is probably going to answer the question that you need answered, which is the potassium really that high? It may not give you exactly the same answer as a regular potassium measurement, but I think it's going to resolve the question of pseudo-hyperkalemia pretty quickly. So I'd be satisfied with a VBG. It's going to give you the information you need.
It's a great pro. Obviously, you can get venous samples, usually a lot faster turnaround from the lab, so that's helpful. Yeah, I think the crux of it really is, in this case, it was tough because we didn't have a prior ECG. It's usually like the first question I ask when I get an ECG put in my face is like, is there a prior to compare it with? It's obviously very helpful. And I think in this case, it made it a bit more challenging.
The other thing is usually when they're super hyper K like that, they're often quite slow, and she was going quite quickly. That's also a little tip that's probably not real.
Yeah, certainly we would expect that with such a high K value if it's real.
The other clue that it was pseudo-hyperkalemia is that the patient had no muscle weakness, because hyperkalemia affects all muscles, not just cardiac muscle. A patient with a potassium that high is going to have severe skeletal muscle weakness. And I agree with Dr. Baymel that the heart rate would not be that fast. So I think you definitely have 5 to 10 minutes of observation on a monitor. But I also think it's a tough ECG, and giving calcium is very reasonable. That will buy you the 30 minutes you need to make sure it's pseudo-hyperkalemia without falling for the trap of shifting the patient, which is a mistake.
That's a great case. I love that pearl about the muscle weakness as well. And it's another sign of another clinical sign of whether it's true hyperkalemia or not. Okay, so I think that's all the questions. So I think we can probably move on to the case number 2. If you have more questions, feel free to drop it in the chat. We can also try to take that up later on or at the end of the presentation. So this is Elaine. She's a 54-year-old female with end-stage renal disease, and she recently missed her dialysis appointment. She presents with generalized weakness and ventricular tachycardia. Next slide, please. She's brought in, she's successfully cardioverted, but now you notice that she's profoundly bradycardic and hypotensive, despite the fact that she actually has a functional pacemaker. You don't have any blood work back yet. Next slide, please. So here's her EKG. Just have this rhythm strip for now. And again, I'll give you guys a few seconds here just to provide an interpretation. Again, the case is a 54-year-old female, missed dialysis, came in VTAC that was cardioverted, but despite cardioversion, still has this rhythm. Okay, Dr. Baymel, why don't I turn it over to you again to provide your expert interpretation of this EKG?
Sure. So Elaine is going super slow. This is a very ominous looking ECG. There's long pauses between the QRS complexes, and the QRS is wide, and I don't see any discernible P waves.
Awesome, thanks for that. Let's move on to the poll then of what to do next. So similar answers to the previous one. So we have option 1 of calcium chloride, option 2, calcium gluconate, option 3, insulin, option 4, D50, and option 5, bicarb. So again, if you're just joining us, the link to the Menti website should be on the chat. You can just put in your answer there. Okay, so thanks for putting in these answers here. Starting to see them roll in. Seems to be a 2-horse race between calcium chloride and calcium gluconate, with gluconate having the slight edge here.
Okay.
All right.
So calcium wins. Excellent. Protect the heart first. You guys are right. Calcium gluconate and chloride would both be great choices in this case. They both work really quickly once they're given to increase cardiac conduction speed and narrow the QRS. The main difference between calcium chloride, as you all know, and calcium gluconate is that calcium chloride has 3 times the amount of calcium as calcium gluconate. So 1 gram of calcium chloride or 1 amp from your crash cart is equal to 3 grams of calcium gluconate. The reason I would sort of choose calcium chloride in this case over calcium gluconate is simply because of convenience. So calcium chloride is easy to grab and give from the crash cart, whereas calcium gluconate often has to be retrieved from the McKesson and drawn up and given. So I'm just usually uncomfortable in these situations waiting that long, but you certainly could. The other option, which I'm showing here, is that you can ask your pharmacy team to put pre-made mini bags of calcium gluconate into the fridge so that they're almost as easily accessible as your gram of calcium chloride for these situations. Next slide. So the EP pearls for this case, hyperkalemia can interfere with pacemaker function. So this woman, Dorothy, had a perfectly functional pacemaker, but it was failing to capture because of hyper-K. And you can consider empirically protecting the heart and shifting if the patient is hemodynamically unstable and not responding to electricity. So what I mean by this is, let's say you're in a situation where you're shocking a wide complex tachycardia and you're not getting any change in the rhythm. It's probably wise in the right clinical context to consider the possibility that you may actually be dealing with a sine wave ECG as opposed to ventricular tachycardia, and empirically giving calcium. Next slide. Any questions?
All right. Yeah, those are great pearls as well. If there's any questions, feel free to drop them into the chat and we'll be able to answer those.
I guess it's Ed's. I have a question, which is, are there any dangers to giving calcium chloride as opposed to calcium gluconate? Are there any situations where it would be unwise? It's not a leading question.
Oh yeah, no, it's a good question. I should have mentioned it. So calcium chloride and calcium gluconate can both cause skin necrosis, so they both should be given through a large bore IV that's reliable. Because calcium chloride has, my understanding, more calcium in it, there's just a higher risk of skin necrosis with extravasation compared to calcium gluconate. But they both can cause the same problem. So try not to use a hand IV. Small hand IV, I would go for something larger, if you can.
Thank you.
Obviously, if it's a resuscitation, then protecting the heart takes priority over that.
Thank you.
No problem.
Okay, so looking at the chat here, I don't see anything yet. We can just move on then to case 3, and then again, if there's any questions about case 1 or case 2, we can always answer those at the end. So case 3, we have Catherine here. She's an 81-year-old female with a history of chronic kidney disease. She presents with weakness, anorexia, and dyspnea. Next slide, please. On her vitals, she's bradycardic and hypotensive. Her potassium is 8.2, and she's got a acute on chronic kidney injury. You also do a VBG, which doesn't show any significant acidosis, and her glucose is normal. Next slide. So again, we'll have the audience take a look at this EKG and provide your own interpretation. We'll give you a few seconds to do that. Again, the case is a elderly female presenting with a history of CKD with a potassium of 8.2 and an acute on chronic kidney injury, the following EKG. Okay, so Dr. Bamal's done all the work so far, so why don't we turn this one over to Dr. Etchels?
Okay, thanks. So my main message here is this is a very concerning electrocardiogram, consistent with the diagnosis of true hyperkalemia. I'm already concerned because of two things I've heard from Dr. Ting already. First is the patient's got muscle weakness. This makes me nervous. Second is there's a reason for the patient to be hyperkalemic. She's got acute on chronic kidney disease, and she probably has some sort of acid-base disorder with a bicarbonate of 15 and an anion gap of 18. So there's lots of good reasons for her to have true hyperkalemia. And this ECG shows signs of true hyperkalemia, even in the absence of a prior. So the first is the T waves. So her T waves in V5 are clearly peaked. It looks like someone has grabbed the tip of the T wave and is pulling it upwards. I also see peaking in AVL and to a lesser extent in lead 1. The second key point is it's not possible to see any P waves. So the next thing that happens is that the P waves get flat and the heart rate slows down and her heart rate is slow. So there's already enough here to justify treating the patient with intravenous calcium to protect the heart and to initiate shifting. The next thing that I would expect to happen would be the QRS amplitude would get shorter and the QRS duration would get wider. In her case, the QRS amplitude is normal and her QRS duration is normal, but we'll have to see what happens after we start shifting the patient. I would not wait for those things to happen.
Very good, very good.
We're on to our next poll.
All right, so another poll here. So the question is, what is your first step for shifting? So option 1 is to give calcium gluconate. Option 2 is to give salbutamol. Option 3 is to give insulin. Option 4 is to give D50. And option 5 is to give sodium bicarb. There's a question in the chat just asking whether the patient's on digoxin. I don't believe that the patient's on any digoxin.
The patient is not on digoxin, and I know why you're asking, and it shouldn't matter because that's a myth. Yeah.
The stone heart hypothesis.
Yeah, it's probably not even true. It's one of those medical dogmas that has basically no evidence base. And if you're worried about hyperkalemia affecting the heart, you should treat the patient.
Okay, so why don't we go to the answers then, and we'll just discuss what the correct one is here. Okay, so this time insulin seems to have the lead here. We also have a few answers for calcium, salbutamol, and bicarb. This one is a little bit of a tricky question. It takes some examination to get the right answer here. Dr. Etchels, why don't you walk us through what the right answer is in this case?
Sure. So I think the right answer is 3, give regular insulin 10 units IV. Number 1 is the right thing to do to protect the heart, but it has nothing to do with shifting. So that was the trick question. Salbutamol is a reasonable thing to do, but it should not be your first step, and that's the wrong way to give it. D50 is also a good thing to do, but it's not your first step. You should give the glucose after you give the insulin. And bicarbonate, in most cases, is not going to be your best first step. So I'm going to go on and go into those in some detail. So just for fun, let's look at the ECGs. So this, to remind you, is our ECG pre-shift. I'm going to go back and forth so you can see the differences, but let's look at the T waves in AVL and V5 first. So you can see that they change quite dramatically, and they're lower and they're less peaked. Second is we're going to look at the P waves. Let's look at V1. That's a good lead. There's no P wave visible in V1 pre-shift. And you can see she has nice normal biphasic P waves in V1 post-shift. So this patient had true hyperkalemia, and by shifting the patient and protecting the heart, you have saved her. It's hard to see on this that the QRS duration is a little bit narrower and the QRS amplitude is a little bit higher. I think the lesson here is those can be subtle changes, and without a pre-shift, without a pre-morbid ECG, you just never know. So you have to make your decisions based on the information available. And the clue here is the heart rate and the P waves. Okay, so let's talk about shifting. So the most important drug to give for shifting is insulin. Glucose, you're only giving it to prevent the side effects of insulin, which is hypoglycemia. There's lots of different ways to do it. What we're giving you is what the United Kingdom renal guidelines say, based on reviewing all of the mediocre to low quality studies of insulin and glucose for hyperkalemia shifting. So you'll have heard of other doses and regimens, but this is as good as any. So give 10 units of regular insulin IV and immediately follow it with 25 grams of dextrose IV. 25 grams is 50 cc's of D50 or 1 amp. And then to reduce the risk of hypoglycemia, if the glucose is less than 7 at the time you give the insulin and the first dose of glucose, run an IV of D10 at 50 cc's an hour for 5 hours and keep monitoring the glucose. Now, we've written frequent monitoring for the first 60 minutes. The UK guidelines actually say you should then monitor for another 12 hours. So I don't know what the right answer is for that, but the message is you must monitor the patient for hypoglycemia. And to reduce the risk of hypoglycemia, run some extra glucose unless their glucose is already greater than 7 when you start the shifting protocol. Next is beta agonists and bicarb. So beta agonists, I think, are the second thing to do. I would only not give beta agonists if the patient had a supraventricular tachycardia. Otherwise, I would give salbutamol. We give it with a meter dose inhaler with a spacer and a mask. Just put it on, 8 puffs. The trick is let the patient swallow it. You're not treating asthma. You're treating hyperkalemia, so you want them to have systemic absorption, which means you give the salbutamol poorly. Let them swallow it. Then watch the heart rate as the salbutamol starts to work. If you're still using nebulizers, then I have the doses. I can share them with you afterwards. Bicarbonate really has no role in the acute management of hyperkalemia unless there's another independent indication for intravenous bicarbonate. I otherwise recommend not giving it, and the UK renal guidelines also recommend against bicarbonate for routine use. There has to be an independent reason to do so. So after the shift, her point of, I think Danny's gonna, I'll read this, Dan. After the shift, the point of care glucose is 8 to 10. Her repeat potassium at 2 hours is 5.1. So we have successfully shifted the patient. So her hyperkalemia is now resolved. Can she be discharged? And the answer is no. So shifting fixes nothing. All you've done is rearrange the deck chairs on the Titanic, but you still have a sinking ship in danger. You have to figure out what the problem is. I think a general guideline is that shifting buys you about 4 hours. After 4 hours, the insulin effect will wear off, the salbutamol effect will wear off, and you are back to square one. So you need to do some homework and figure out why the patient is hyperkalemic and initiate initial management. So we're finishing the last two principles. We've talked about protecting the heart. We've talked about artifact. We've talked about shifting. Now we're talking about eliminating potassium from the body and not adding any, and then determining the cause. These are closely coupled activities, but we're going to separate them for artificial reasons. So there's only one really proven way to eliminate potassium from the body, and that's to establish urine flow. If your patient is not urinating, then it is virtually impossible to get the potassium out of the body efficiently. I'm going to talk about gut in a second, but it's not your go-to emergency room strategy. You must establish urine flow. I can't think of a better indication for a Foley catheter than hyperkalemia. My rule with my residents is I need to see at least 150 milliliters every 4 hours of urine flowing, or I'm not happy. And that's a minimum. If the patient has known end-stage renal disease, if they're already on dialysis, or if they have a nephrologist that they're friendly with, I would get that nephrologist on the phone because you're going to have trouble. If they're hypovolemic, I suggest giving them normal saline. I know there's emergency room literature about Ringer's lactate. I don't think there's a role for Ringer's lactate in the management of hyperkalemia. I'm not saying it's going to cause hyperkalemia, but it makes no physiologic sense to give something with potassium in it when you're treating hyperkalemia. If the patient is obstructed, you must identify and relieve that obstruction. Melanie's going to talk about that a little bit more, but I'll just tell you that the first electrolyte disturbance in obstructive uropathy is hyperkalemia, because you need urine flow in the distal tubule to excrete potassium. And if the patient is hypervolemic and there is some urine flow, give them some furosemide and see what happens. Do not give them oral potassium, obviously. I only say that because my view is these patients should be NPO until the situation settles down. First of all, they might arrest in the next 4 hours. Second of all, why would you let them put potassium in their body when their biggest problem is you're trying to get potassium out of their body? So I'm very strict about this. I've been told I'm harsh, but make your life simple. Keep their stomach empty for a few hours. And please don't give them anything with potassium in their intravenous. I've already talked about Ringer's lactate. Don't let them take their home medicines, because a lot of them have potassium in it, and we're going to see they're a major cause of hyperkalemia. Now we're going to move on to figuring out the cause. So the first general principle is there's almost always impaired urinary potassium excretion. This can be from an acute kidney injury, and I've mentioned the importance of obstruction. This can be from chronic kidney disease, obviously patients with end-stage renal disease with missed dialysis, and obviously medications. These are the common offenders: ACE inhibitors, ARBs, potassium-sparing diuretics. Remember, there's a lot of combination diuretics where there's a potassium-sparing diuretic lurking in the background. Septra is notorious. Septra, the trimethoprim, is exactly a similar chemical structure to amiloride, which is why it causes potassium hyperkalemia. It impairs potassium excretion at the distal tubule, and nonsteroidals are notorious causes of hyperkalemia, that are non-prescription. Potassium ingestion on its own should not cause hyperkalemia. Almost all of these patients also have impaired urinary potassium excretion. Obviously, dietary indiscretions in the end-stage renal disease situation. But remember, there's prescribed potassium, and any person can go to Loblaws and purchase potassium chloride because it's in the salt substitute section. So when we tell our patients with heart failure or cirrhosis to reduce their salt intake, they may unwittingly go to the grocery store and start taking potassium chloride and cause hyperkalemia. I always ask the patients if they buy salt substitutes. Less common causes, although perhaps more common for you, beyond reduced insulin action, so cellular shift, acidosis, and the other medication is beta blockers, and cellular release, major trauma, and less commonly tumor lysis syndrome. I think these are less common situations. Impaired urinary potassium excretion with potassium ingestion cover most cases. If you go through this entire list and you cannot figure out why the patient is hyperkalemic, please remember this: they probably have hypoadrenalism. So if you're scratching your head and it doesn't make any sense, please remember that pearl. The patient may have hypoadrenalism, primary hypoadrenalism. Melanie, any comments?
There's a few questions in the chat here.
Okay.
First question is, will D50 amps induce endogenous insulin production?
Yeah, it's a really good question. And I've asked this of some of my friendly nephrologists. First of all, there's no studies of just giving glucose. Second of all, in theory, giving glucose on its own might work, but you can't control the patient's insulin response. And this is a situation where you want to make sure there's a lot of insulin going on in the patient's body. Third, you don't know their insulin receptivity. So if they've got undiagnosed type 2 diabetes or impaired fasting glucose or impaired glucose tolerance, you don't know what you're accomplishing by giving them just glucose. So I would recommend against it for those reasons. Finally, there's a theoretic reason not to just give glucose. There are studies to show that if you just give glucose and cause hyperglycemia, there can actually be transient hyperkalemia through a process called solute drag. As you drag water from the intracellular to extracellular compartment to deal with the hyperglycemia, potassium is dragged out unwittingly. So I do not think you should give just glucose. You should always give insulin. And then the only question is whether to also give glucose. And the answer is always give them 25 grams. And if their glucose is less than 7, give them another 25 grams as an infusion. And
I would say it's just
monitor.
Yeah. It's so important because, I mean, the insulin will last like 4 hours, whereas the glucose only lasts about an hour, that amp D50. So about 10% of your patients will become hypoglycemic, and your CKD patients, I think the stat is around 30%. So keeping a close eye on things or just running a D10 drip in the background is probably a good idea.
Yeah, so that's a great segue to this other question, which basically says, in renal failure patients, do you give more than 1 amp of D50? I find they often become hypoglycemic, even if initially hyperglycemic, as they can't clear the insulin.
Yeah, again, I'll just start by saying the studies aren't great, and you're going to get different opinions. I think the UK guidelines are a very reasonable start, but no one's going to criticize you if you run D10W at 50 cc's an hour for 5 hours after you give the intravenous insulin, even if the glucose was 8 when you started. Because a little bit of hyperglycemia is not a huge disaster. Acute hypoglycemia is severe.
Okay. And then maybe we'll just do one more question before we move on. There's another question about fluid choice, Ringer's lactate versus normal saline. And the question is there any evidence for Ringer's lactate exacerbating hyper-K? I am under the impression that this is a persistent myth.
Yeah, it's a good question. And Melanie and I went over this when we did a similar webinar a few years ago. So I read those studies very carefully. So the whole Ringer's lactate story and potassium story comes from studies of giving large volumes of normal saline, usually in a perioperative setting, in patients who are eukalemic. And if you read the exclusion criteria for those randomized trials carefully, they exclude patients with hyperkalemia because of the theoretical concern of worsening hyperkalemia. Second point is those studies tend to give large volumes of normal saline. For example, one of the randomized trials was on patients undergoing renal transplant who got 4 liters of normal saline compared to 4 liters of Ringer's lactate. So I really think it's immaterial in the acute management of hyperkalemia, and I think it's inappropriate to give Ringer's lactate. Now, after the 4th liter of normal saline, if it's indicated, I'm willing to discuss it. But until
You've probably
then,
corrected that hyper-K by that point
yeah,
if they're making your own.
exactly. But I think I would say your first 2 liters should be normal saline, and then you can see where you're at.
That's a great answer. So why don't we move on then? There's a couple more questions in the chat, but why don't we just make sure we finish the presentation, and if there are still some more questions and time at the end, we can go through them.
Okay. Ed, I think you can populate this slide. All right. So, in the Emerge, we often defer to our consultant, Ed, to sort out why this patient is hyperkalemic. But I would encourage you to do a simple bladder and kidney focus. You can quickly determine whether or not they're obstructed, and that can change our management in AD and certainly help with disposition planning. So if you're giving fluids and they're persistently have low urine output and you don't see any signs of obstruction, then the right person to call is nephrology, because likely they're going to need dialysis. Next, if they have low urine output and you see, for example, a big distended bladder on POCUS, then the next best thing is a Foley catheter. And if you see significant hydronephrosis, then likely they're going to need decompression with either urology or interventional radiology before calling nephrology and thinking about dialysis. And then finally, as Ed mentioned, this is such a great pearl that doesn't come up very often, but it's important to have in the back of your mind. If you have a patient with hyper-K and they have unexplained persistent hypotension despite adequate fluid resuscitation, consider the diagnosis of adrenal insufficiency, send off a random cortisol and ACTH level, and give a dose of IV hydrocortisone.
Okay, thanks, Melanie. We're going to finish by briefly talking about eliminating potassium through the gut. I'm going to reiterate my statement. The urine is the most important method, and for emergency room setting, you must establish urine flow, top priority. I think the gut in the emergency room is not that important, but there'll be some discussion over that point. What I do is, first of all, I ask the patient if they're constipated. If they're constipated, I'm going to give them an osmotic laxative, because it's not good to be constipated, and you will get rid of a little bit of potassium that way. I do not think there is any role for Kayexalate or calcium resonium in the emergency management of hyperkalemia. Their efficacy is uncertain, and there's a black box warning on both of these drugs because they can cause gut necrosis, which can be fatal. And the evidence is very poor for both of these drugs. In fact, some small randomized trials suggest that their major effectiveness is derived from the sorbitol osmotic laxative, not the binding agent themselves. So I don't use these drugs urgently. I don't really use them non-urgently either. I don't think you should use them at all. Then we have the new expensive potassium binders that you will start to hear about. The first one is called patiramir. I don't think it's of any value in the emergency room. It takes at least 7 hours to start working, and the randomized trials show that it drops the potassium 0.3 to 1 millimole per liter over a month. Not helpful. The next one is called ZS9. It can drop the potassium quickly. So it will drop the potassium by 0.5 millimoles per liter over 4 hours, about 0.7 millimoles per liter at 24 hours after a single dose. So that may have some value. I read these trials in preparation for this webinar. Honestly, I've never used this drug personally, and I acknowledge that. This is what I felt about the studies. First, it's not being studied in emergency room settings at all. It's been studied in settings of patients with chronic hyperkalemia with impaired renal function who are ambulatory, or patients with heart failure who are on an ACE inhibitor and a potassium-sparing diuretic and running into trouble with hyperkalemia, and you're trying to keep them on those heart failure drugs rather than stopping them. Most of the trials include patients with mild hyperkalemia, very limited data on patients with potassiums over 6. The trials include a run-in phase that exclude 10 to 15% of patients where it didn't work or they couldn't take it. The problem is you don't know which patients those are. And I'm a very suspicious person. Studies were performed by researchers affiliated with the drug company. Having said that, it's probably got a role. I made some notes about where I think it might be helpful in very limited situations. So if the patient's already on ZS9 and has it with them, and they're not vomiting and they're having bowel movements, seems reasonable thing to do. If you talk to the consultant nephrologist and they recommend you do it, I think it's a reasonable thing to do. Other than that, I'm not so sure, and I look forward to the discussion. Dan, I'm going to hand it back to you to wrap things up.
Awesome. Thank you for that. So just to go over quickly our 5 principles that we covered in today's webinar. Number 1 is protect the heart. So remember to use calcium, whether it's calcium chloride or calcium gluconate, especially if there's any ECG changes. Think about artifact. Repeat, potassium can be very useful. And they can usually be monitored for a few minutes that it takes to get that, if that's what your suspicion is and they don't have any other signs of hyperkalemia. It's very important to shift potassium. So we talked about using insulin, glucose, and then Ventolin. You obviously want to eliminate potassium. You don't want to exacerbate the problem. And that's primarily going to be through the kidney and establishing good urine flow. And finally, determine the cause. And some of the big causes that jump out at me include obviously renal insufficiency, renal failure, medications. Those are some of the main things to keep an eye out for. Okay, so I think let me just move on to the next slide there. Okay, so treat the patient, not the number. Consider hyperkalemia when you're having difficulty with pacing or cardioverting. And then, of course, remember, once you fix the hyperkalemia, it's not the time just to discharge the patient yet. You've got to really work them up to find out what the reason for them getting in that case in the first place, or else by the time they get through rush hour traffic and get home, they'll be hyperkalemic again. So that's a really important one to mention as well. Okay, so I'm just looking at the time here. We have a few minutes here for some more questions. I'm just going to look at the chat. The first one has to do with GI elimination of potassium. Zirconium salts have new, better evidence, says one comment. Do you use it? I would say no, I haven't personally used it, but I'll see if Dr. Etchels has any more expertise on this topic.
As I said, I personally have never prescribed these drugs. My nephrology friends prescribed them for their outpatients with chronic kidney disease, end stage, or on dialysis, and there's for sure a role there. They prescribed them in the heart failure clinic for patients on drugs that reduce potassium excretion that are otherwise important for changing long-term cardiac prognosis. I just think the role of these drugs in the emergency department is uncertain, and I would strongly urge you to focus on establishing urine flow, not adding potassium, and determining the underlying cause before then prescribing these new zirconium salts. One other potential situation, I think you should always be talking to a nephrologist before you give these drugs. If you're in a setting where the patient probably needs to be started on dialysis, and there's going to be delays or transportation required, and the nephrologist says, please give them a dose to buy me 4 to 12 hours. I think that's a very reasonable scenario, although not scientifically proven, it makes sense. But I don't know how often that scenario will arise. I don't know what Dr. Baimel thinks about that.
Yeah, no, I think it may end up playing a role in low resource settings where you don't have dialysis at your center and you're having to transport the patient out, or the patient's reluctant to go. But the cost is still going to be an issue right now, because just to start, I can't remember how many packets. I want to say 6 packets cost at least a couple $100s. So, yeah. And right now, even in big academic centers, at least at Sunnybrook, we don't have an available needy, so it's not something that we can easily order at the moment. So at the moment, it's not super accessible or cost effective, but perhaps in the future it will be. The other thing I can see happening is perhaps maybe less patients come in with hyper K, hopefully. If they're being treated by their nephrologist, they get a blood test back instead of reflexively sending them back into the emerge. Maybe potassium is such that the nephrologist feels comfortable starting this medication and not sending them to us. So it might help a little bit with ED volume.
Yeah, that's a very good point as well. I'd also say that at Vancouver General, which is a high resource setting, I've never actually seen any of these binders stocked in the emerge or not used. So, but maybe it's something to keep an eye out for the future. We also have another question, just kind of going back to basics. We always talk about calcium protecting the heart. What does it actually mean how does calcium actually protect the heart?
That's a good question. It's a complicated answer. When you're hyperkalemic, the difference between your threshold potential, I don't know how detailed you want me to get into it, and your resting membrane potential it reduces. So it's the myocytes become they're more easily excitable, and your conduction speed decreases. So the speed of the action potential, the flow of sodium down its gradient is not quite as quick as it normally would be. So your cardiac conduction speed changes, and that's why that QRS widens. So by giving calcium, you actually increase the threshold potential. So the difference between your resting membrane and your threshold potential go back to normal, and your cardiac conduction speed goes up. So that's how you protect the heart. It goes back to like your chemistry experience from undergrad. Okay. It's easier to explain that in graph form.
Okay. Just seeing if there's any other questions in the chat here. There's a question about using IV Ventolin as a shifting modality, which I've only ever seen in the ICU setting for severe asthma. I'm not sure if Dr. Eschels, Dr. Baimel, if you have any thoughts on that.
I mean, it would work. I don't know what the dose would be, but physiologically it would make sense. I'm not aware of any studies of that approach, but you could do it. I just think that 8 puffs of Ventolin through an MDI is very available, very practical, and very easy.
Mm-hmm. Okay, and then one other question, maybe the last one here is there any role for hypertonic saline or bicarb in a wide QRS situation, with the thought of K being a sodium channel toxin?
Dr.
I know how Ed feels about it.
You handle all the wide QRS.
I'll be honest,
questions.
like I do give bicarb if the patient is pre-arrest or in an arrest situation. So because I'm just gonna assume they're acidotic and it may help, and anything is helpful in that scenario. And I do. I don't wait to see if the calcium works. I kind of say, can I have an amp of calcium and bicarb? And the calcium goes in first and the bicarb goes in second, not through the same line. But in a patient who's stable, I agree with that. I would only be giving bicarb unless it was indicated for some other reason.
Yeah, I'm agreeing with you. I'm just saying, give bicarb if you would normally give bicarb for whatever's wrong with the patient, but don't give it to them because of their hyperkalemic. If they're pre-arrest or if they have a severe metabolic acidosis that you would normally manage with bicarbonate, sure, but don't do it just because they're hyperkalemic. Hypertonic saline, I don't think there's any role for it in the management of hyperkalemia. Dr. Baimel, do you agree with that?
Yes, I would agree with that.
Yeah. There wasn't any mention of it in the UK guidelines either.
Okay, so I think we're just coming to the end of the webinar here. So thank you so much, Dr. Baimel and Dr. Etchells, for sharing all your wisdom and clinical pearls with the audience today. I'm sure that everyone learned a ton. The session has been accredited by the College of Family Physicians of Canada, as well as the Royal College. So you can complete your evaluation form if you want to claim your credits. And a certificate of attendance will be mailed out by CAPE along with the eval link. Finally, this is not just the only webinar that's happening. There's many webinars that will be happening in the future with CAPE. So please keep an eye out for more information about this, and hopefully you'll be able to join us again soon. Thanks again.